Hey, Bill, can you hear me?
Yes, I can.
Okay, good. I was having problems with my audio, so sorry, I had to go in and out, in and out, and come back on. But I guess now it's working good. Okay, fantastic. Good morning, everybody. It's 9:30. I'll get started so we stay on time. We will count up and make sure we have a quorum. Bill, if you can start doing the counting for me, that would be great.
Okay.
And what we can do, we could do you want to do a roll call, Bill? It'll probably be easier for you, right?
Yes.
Okay, so go ahead and do a roll call for me.
Dr. Murphy,
Yes.
Dr. Papish,
Here.
Dr. Rashad.
Good morning.
Morning. Dr. Stu Miller,
Good morning.
Dr. Brutus, Dr. Crissard, D. Crissard, Dr. McKinley, Dr. Mao,
Good morning. I'm here.
Dr. Chung.
I'm here. Good morning.
Good morning. Dr. Midori, Dr. Templeton, Dr. Greenhut.
President, we'll need to drop off early.
Okay. Dr. Mead, Dr. D. Thomas,
Morning here.
Dr. Brutus, Dr. Cohen,
Present.
Dr. Santos, Dr. Kakuza, Dr. Larson, Dr. Quintero. One, two. We have 9, Dr. Murphy, so that's a quorum.
So that's a quorum. Great. Thank you, everybody. So this morning, I'd like to start with if anyone has reviewed the minutes and if we could have an acceptance or approval or any additions, deletions, or corrections you need on there. They were pretty succinct and straightforward, so there wasn't much to read. So I don't think there's much to go on, but could I get a motion to approve?
Motion to approve. It's Dennis.
Thank you, Dennis. And a second?
Second.
Okay, Dr. Mark Papish, thank you. All right, moving on, we'll go to some of the old business. We brought forward to CMAC the Agile pilot project. It went really well, actually. It was well received. There's a few things we have to do for it, and we will. We've actually, Todd Van Buren, he's been working diligently on this project with me, and kudos to Chad Burkhart for a great PowerPoint on the project. We're submitting the not corrections, but things they wanted clarified on there. So it's probably going to move along pretty well. The one thing most people were asking is, could they be involved? There's a lot of people that want to be involved. The problem is going to be David Violante sits on a training and ed. So he brought it there because we have to talk about, is it within the scope of practice of the EMT? So David, do you want to talk about what happened at training and ed?
I do not believe he signed in yet.
Oh, okay. Okay, sorry, guys. So basically, it was, something we have to go and wait on the state to approve. It has to go to the commissioner because it is outside of their scope of practice as it stands. We were looking at it as an adjunct to their airway process and thought that it still fit the scope that was written there in their guidelines. However, we may have to do a little bit more tweaking of it. But on the first pass, it went really, really well. They were very excited about it. COVID-19 vaccination administration. Did you want to talk about that, Bill?
Well, the only thing is it has been progressing. I want to make sure that all of our A1 people that wanted to be vaccinated have been vaccinated. And if there's any problems or questions that, they come forward to us and we can take them either to Director Greenberg or to the vaccination task force. So we have some options if people haven't been able to get vaccinations on the EMS side.
And two things, I get notified when Orange County Department of Health gets more vaccines. So they're getting 1,000 Moderna doses this week. So just FYI, they will be opening up some pods so people can go on and look to see. In addition, we should be getting right here at Garnet 1,000 doses or 975 of Pfizer this week. So there's a bunch more coming, another round. And as you all know, Johnson & Johnson was approved for emergency use on Saturday. It will go into now a process of being distributed. It's definitely not as many doses as they thought was going to be from the first pass. However, as you know, it's a one shot, one dose vaccination. So it's going to make it a lot easier for a lot of people. Service upgrades. So I don't have any service upgrades, but I have a couple of BLS agencies that have requested and added adjuncts to their armamentarium. The town of Patterson added on glucometry. We submitted the application February 10th. Legoland, New York, yes, the resort right here in Goshen has applied for a pad site, and that was submitted and passed through on February 10th. And RNL, which is one of the manufacturers, also a pad site for February 26th. So we just need to have approval on those. Anyone who has any issues with it, let me know. But I will take without anybody saying anything of the difference, I'll take those as an approval rather than go through a roll call again. And if anybody has any questions or concerns, just let me know. Next is the evaluation subcommittee report. Dr. Ashad.
Hey, good morning, team. So there are two cases that I wanted to bring to everyone's attention today. One is old and we were just waiting for some updates. We do not have all of those updates at this time, but I think in consultation with Jeff and others, I think it's appropriate to present, and one is more recent. So I'm just gonna pull up my notes. I'm gonna just try and keep this de-identified and avoid sharing my screen. But the first case is unfortunately sort of like a Lazarus phenomenon. And it was a sentinel event notification, and it was referred by the medical examiner and law enforcement to New York State Department of Health. And the call type was for a 911 response to an unresponsive elderly woman. Fire was on scene and had initiated chest compressions. The medic unit arrived and continued ACLS for over 40 minutes. And ultimately, they made a request to one of our local hospitals for field termination of resuscitative efforts. They administered 3 epinephrine doses, and a supraglottic airway was also inserted after a failed endotracheal attempt. The reason this was referred to us is upon termination, the patient was noted to have agonal respirations. The medic called medical control, got the initial order to terminate. The patient, then resuscitative efforts were stopped. There was no palpable pulse, but there was still organized electrical activity, so they called it PEA. And after 40 minutes and 3 EPIs, they got the orders to stop. The patient did not have a palpable pulse. Once they stopped, they kind of noticed that the patient had some agonal respirations. They called medical control again and were informed that that was, essentially per documentation of the PCR, that could be an expected phenomenon related to an intact brainstem reflex. The reason this turns into a case is The medical examiner arrived 3 hours later to the patient's home. And they found that the patient had agonal respirations. They requested that, and a palpable pulse. So they requested EMS be recalled. A second ALS unit responded approximately 3 hours later, and the patient had a palpable pulse. They got a set of vital signs, and though the patient was hypoxic, had a very low blood pressure, and was bradycardic, they were able to BVM the patient, give normal saline and a single dose of epinephrine, and got the blood pressure up. The patient ultimately presented to a member hospital and was intubated. We made an attempt, or rather the state did, just to get some ultimate outcomes data, what eventually happened to this patient. Did the family withdraw care? We don't have that information because the hospital just had referred it to their in-house legal team, and were reticent about disclosing that information. So ultimately what happened is the medical director for the agency placed this paramedic under a restriction. There was a pretty extensive remediation process, and the paramedic did ultimately clear that remediation and is back to practicing at the ALS standard. I know the paramedic personally and essentially know him to be incredibly competent, skilled. This is a very unfortunate case. I'm not sure even if they had obtained ROSC at the initial resuscitative event that the patient would have had any meaningful neurologic outcomes. Nevertheless, the agency did do an internal QI process. There was some re-education related to deviation from standards of protocols. There was some concern in the PCR related to interpretation of the capnography reading, and ultimately the paramedic was appropriately remediated and re-educated on it. So that's kind of the summary of case one. If there are any questions, I'll just pause to take comments to fill any gaps or things that people may have comments on.
How did that patient survive so long without any intervention? 3 hours later was the last medic to come on.
3 hours.
Yeah, that's pretty impressive resiliency there.
Yeah, and I think the medical,
terrible case.
It's a terrible case. It's the Lazarus phenomenon. It's we've all heard of the patient coming back when they're in the morgue. The psychological toll on the husband, though, I think was pretty severe.
How old was the patient?
70.
Is there anything from like a system standpoint? I mean, obviously the provider, misinterpreted several things. But is there anything from a system standpoint that could be improved, you think, from the case that you saw? I mean, the medical control.
Yeah, great question, Mark. I was not able to review the medical control call, but I think one thing that we should standardize and train, and this is something that we teach our residents also, is that when you feel this medical control call, one of the most important questions you can ask is, what is the end-tidal CO2? And that's really going to be the best determination if you've achieved ROSC and or if the patient really is unsalvageable, which is a term we hate to use, but after 40 minutes of ACLS, in terms of intact neurologic survival and hospital discharge, we obviously know that the patient has significantly less than 1% chance. So from a systems perspective, in terms of training our residents, one thing that I do focus on is making sure that they ask, what is the current end-tidal CO2? And I think that I've been surprised when I ask this question, the medic will oftentimes say, hold on, doc, let me just connect that. So I think we just have to make sure, maybe we can do an internal QA process to see what percentage of cardiac arrests do have continuous waveform capnography. Yeah. And we can do like a mini QA process to determine when folks ask for termination orders, to make this like a required part of the template. Those are just the couple of things that I was contemplating, but I'd love to hear other people's thoughts as well.
When you asked the gentleman in this call, he didn't have one, he didn't understand it, or he misrepresented it. I forget what you said.
So the way the PCR comments on it is the end tidal CO2 was 50 to 60. It's unclear the time frame when that occurred, but sometime earlier on in the resuscitation, and that was not communicated in any way to the physician. That's for sure. In the PCR, is documented as being in the 50 to 60s, and the paramedic misinterpreted that to saying the patient was being hyperventilated, and they directed the EMT to slow down the bag valve mask. We of course know that's the opposite. If the patient is being hyperventilated, we would expect a low end tidal CO2. So that was part of the agency and the medical control remediation process.
Wow.
And you have a second case there, Shad?
Yeah, and if anybody else has any additional commentary that they'd like me to privately share regarding this case, you can certainly feel free to send me a direct message.
I would just say, it's Ray Rich. I would just say that, clearly that end tidal CO2, right, is a cognitive error, but to Mark's point, I think it is a system issue, and, there's very good literature on the predictive value of end tidal CO2 in resuscitative efforts. So I think that's definitely an area we could explore further.
Do we want to discuss how exactly we would shape that project now, or should we save that for later and as I present the second case?
Well, we could talk about that. We could take it offline, but one of the things could be is we sponsor a web forum and do an educational process on it. And by utilizing some of the resources around, we can, really remote it out to a lot of places.
I mean, it's not part of our current termination protocol,
No.
but maybe it should be.
Oh,
Right?
that's interesting. Yeah, I wrote one of the protocols for the city back in the day, so I have that handy too. And how about Bill and Jeff? Any other thoughts or ideas, suggestions? Mike, Dave?
No, I think your idea is fine. I think you should pursue that.
I agree.
So, also, I think that probably if there was one or two protocols across the state that continue to cause the most angst amongst all of the providers is field terminations. And so I think that certainly is a significant learning opportunity here for us to educate all of the providers. Everybody doesn't think that this will ever happen to them. And obviously neither did that paramedic on that particular day. So, I think we can seize this as a good training opportunity, and also a, real good QI study to show, what's important.
And I think like most QI stuff, it usually is a systems problem. It usually is a process problem. Granted, this gentleman was off on his identification and knowledge of his end title. But as a general rule, most of these things bring up points of what could we improve upon. And this might be one of them, like Mark said it, like Arshad said, is we add it to the protocol for declaration.
Cool. Well, I'm definitely excited to work on that further. If there's anybody else that's also interested in working on that, please don't hesitate to send me a direct message or just in the chat, just reply all. If you have any, also I just wanted to plant the seeds. If you have any interesting projects that a trainee could potentially benefit from, I think we should start at the regional level looking at those, since we are starting to grow emergency medicine programs here in the Hudson Valley ourselves. So it's a great way to collaborate and advance the evidence base for EMS.
Yeah, so
All right.
academic labor.
And academic labor, yeah. All right, next case is a recent one that presented to my hospital. So it was referred to me for QA review, but also was referred to the region. So it is a cardiac call where a BLS squad responded, a 61-year-old with a history of atrial fibrillation on Eliquis, called 911, increased sensation of palpitations and chest discomfort. EMS arrived on scene. There's some deficiencies in the PCR in regards to commentary on whether ALS was available or not, but the initial blood pressure was 94/66 and the heart rate was 179. The repeat BP, repeat blood pressure was 92/62 with a heart rate of 224. The reason this was referred to review is the BLS squad did a 12-lead EKG, which showed atrial fibrillation with a rapid ventricular rate of 173. There was no documented medical control contact prior to arrival at the receiving facility, and the patient was transported BLS with no documentation of either an ALS agency not being available to intercept. And when you kind of map it out, they passed by 4 different ALS provider stations. When the patient arrived in the hospital, they received IV diltiazem. The EKG confirmed atrial fibrillation with rapid ventricular rate, and the patient was ultimately admitted in stable condition on a diltiazem drip. So kind of our commentary on this one was a focused re-education. We're very excited that BLS providers are taking the opportunity to do and perform 12-lead EKGs, number 1. Number 2, they're doing it with appropriate lead placement and a good understanding of the indications for 12-lead EKGs. So those are all reasons to celebrate. So just to acknowledge that, and again, regarding the systems-based issues or areas for improvement, we just have to remember that all BLS EKGs must be transmitted to the base station for interpretation, not only if there's an abnormality or if there's a question. All BLS 12-lead EKGs must be transmitted to the base station for interpretation and further instructions. So Jeff and I are going to, so the chief of this particular squad did do a QI process with them. The crew was remediated, re-educated. They have a good understanding of kind of their limits and scope of practice, the potential for decompensated shock and cardiac dysrhythmias, and you know, really the significance of having ALS on board for this type of call, where we can establish IV access and administer cardiac medications, and potentially, if we determine this to be an unstable AFib, you know, potentially shock. So those are all learning points. We are going, the crew was re-educated, but I think we're going to, Jeff and I are going to just write a letter re-emphasizing and re-educating those points to that crew. And then we also do at Vassar do a 12-lead STEMI review every month. So we're gonna just invite that squad and that crew in particular to join us. Any additional thoughts, questions, concerns, or recommendations?
So I think that this is just another case like the last one where these are great learning opportunities for other folks. And so I'm just trying to process how we can educate all of the providers in the region as a result of these. Certainly in this area, a day does not go by when ALS is not available. And we need to realize that the hospital is the closest ALS, but documentation of that is critical as well. And certainly also the transmission of all EKGs, regardless of the outcome. Anytime it's done, it needs to be transmitted. So I think those are, you know, some real take-home points that we need to figure out how we can educate and what tool we can use to educate the providers.
Excellent points. Anything else, Fazan? Okay. So from that first case, let's take a little offline and we'll do something to work up the educational process. I see it in my vision that you'll make a nice program to teach everybody about end-tidal CO2, and we'll blast it out there. What we'll do is we'll make it an official CME and just have everybody sign on, and we'll try to get people grouped into stations so that we get the biggest bang for the buck.
One question I'll have for open business is, is there any consensus amongst the group on when we're going to start doing in-person CMEs more regularly now that community rates are declining and vaccination rates are increasing? I don't have an answer to that, but we just decided for the residency we're going to be back in person in March. So I'm wondering if other people have thought about those questions.
We went back to in person for our residents too. That educational process is pretty amiss without it. However, I have to tell you, Fazan, the rates of our pre-hospital providers getting immunized is very low. It's unfortunately very low. So that was one thing that, you know, all of our residents took it, all of our doctors. We have like a 98 percentile for the providers taking the vaccination. So that's the one thing that led us down the pathway. This is a much better way. We don't let them eat. We definitely still have them keep, you know, 6 feet apart. We have a big, huge room we opened up for them. So there's definitely still strict criteria. But in terms of CME around the horn, I don't know. It just would be something I think we can make a recommendation on, but I'm not sure we can tell what agencies what to do.
So just to comment, we recently have started PALS and ACLS in person again and have some intention to beginning other programs in April. I think what's important is that we continue to make them a hybrid so that they're available for in-person as well as online for those that are not comfortable in doing that, and certainly also watching total numbers. So I think that probably, you know, a blended hybrid is probably the way to start going in a lot of the instances.
Any other comments? Anybody have any, are they doing anything different at their places? Anything that, you know, you want to add? Okay, that being said, did somebody say something? Okay, maybe not. So next is New York State Department of Health Enforcement notifications. I only have one this morning. It's from an Andre Volek out of Brooklyn, New York. The effective February 17th, it is a violation of Part 800, and he will be forfeiting his certification for right now as the result of an investigation conducted by the Department of Health. It was surrendered February 17th, 2021. That's my only notification.
Pam, I have several more that have to be added to the record.
Oh, okay. Go ahead and read them. That was the only one I got on the email. Go ahead and read them.
Okay, it's
Just
Fritz.
do them abridged. You don't have to do crazy detail, just the name and date and what the infraction was.
Okay, Fritz Bartov, Barotov, violation of Part 800, and his let me see, his state certification was surrendered effective 1/17/21. And then I had please civil investigation conducted by the following for New York State certification. Assessed a civil penalty of $25,000. Of that, $12,500 is suspended pending completion of a 2-year period of improvement of performance effective 1/22/21. Engage a consultant from the New York City REMSCO to assist the agency with the Part 800 Article 30 compliance. Submit a correction plan within 30 days as of 1/22/21, and submit a current DOH 1118 within 30 days of the plan of correction. Vehicle fleet is limited to the number in service as of 8/26 upon compliance with the plan of correction and improved inspection for 6 months. The department will accept certifications for these additional vehicles. So it was for violations of Article 30, Section 3012, 1B, Part 800, Section 21, Section 3, Section 24 and 23, it's citywide mobile response. And that's it for that one. Now I got another one for Newark Arcadia Volunteer Ambulance, surrender of 1 year, suspended for 1 year, effective 12/22/20. The suspension is stayed pending full service inspection and no further violations in 3 years. They were assessed a civil penalty of $5,000, and for violations of Part 821, 823, 805, 824, 824 again, a couple of more, and Public Health, Article 30, 3012(1)B. Then I have one more, which will be my last one. It is for South Farmingdale Fire Department, and it was suspended for 1 year, effective 1/19/21. The suspension is stayed pending no further violations for a period of 3 years. Assessed civil penalty of $2,000 for violations of Part 800.23 and Article 30, 3012, Section 1, subsection B. And that's what we have. That's the rest of it.
Okay, great, thank you. Next is helicopter committee report, Dr. Stu Miller. I hope everybody was able to look at, they sent out the revised, air medical guidelines. Karen sent them out to everybody on the committee. And I just want to make sure everybody takes a look at them. And Dr. Stu Miller, any report?
Thanks, Dr. Murphy. We welcome any comments on those guidelines, which are now live. We met this morning as a committee. The only two items to report is that Hackensack University Medical Center AirMed 1 has successfully navigated the state of New Jersey to carry low titer O negative blood on their aircraft coming soon. And we all hope there will be someday when state of New York allows air medical services to carry blood products. So New York can benefit in the ways that other states, every other state really has the ability to carry blood. And secondly, the LifeNet of New York program will be beginning monthly CE events. The first will be March 10th at 7 p.m. It's on airway management. And there's a website where anyone can sign up and then get CE credits. The website is lifenetcenight.com, all one string, lifenetcenight.com. And that's all I have for the committee.
Thank you, David. I recommend everybody to take a look at those guidelines that they sent out. They're really well written. So just make sure, and I would make them available for staff at each one of your facilities. I think it's something everyone should be familiar with. And to look at, they actually have some, guidelines in there, great things about all their capabilities, all what they do, their aircraft, their abilities and how they differ in function. It's actually very well written. Thank you to the committee and Dr. Stu Miller. RTAC, Dr. Larson, but I don't think Dr. Larson is on, right? Bill, were you at RTAC?
I haven't heard of any RTAC meetings.
Okay.
They said that we did get an email.
Yeah, there was a notification, right?
Right, that they were going to start shortly, but we have not been told of any that have started. At least I'm not aware of any.
Okay, that makes that easy. Quality improvement, Jeff.
New York State, in cooperation with ImageTrend, has created a free version of the EPCR program for BLS-FR. We're working on getting agencies onboarded. We've got probably 60 agencies that need to be compliant in the next couple of months. We're working through setting them up on the bridge, getting them trained. New York State has training sessions. We are supplementing those as needed for folks that can't make those times. Other than that, we continue to create reports from our bridge and put the results out to the agencies so that they can utilize them to improve.
Jeff, did you say
It's
that
a busy
was
start
free?
of the year. What's that, Mark?
Did you say it was free?
free, but it's a limited data set. So BLSFR, we don't get much data. Well, we don't get any data from BLSFR as it stands. So this data set will at least give us some demographics on the patient. When they administer Narcan, we'll be able to glean that information. Anything on the first part of a cardiac arrest, we'll be able to get. You know, it's limited, but it's more than we had. So that being said, at the end of the year, there will be no paper PCRs, period. We still have a couple of transporting agencies that are kind of coming into this kicking and screaming because they say they can't afford it. It is the cost of doing business. And I think something that EMS agencies in general have not responded well to is the fact that you're a business. And there are costs to doing that business. And I think that's why a lot of BLS agencies, particularly volunteer in general, are in trouble because they can't run the agency today the way they ran it 40 years ago.
But really, it's not that different. I mean, I can understand how the implications on the transport services, because they've got turnaround times and whatnot. But like for the BLS agencies in general, I mean, they have to buy an ambulance, they have to buy radios, they have to buy, you know, so
Yeah, this is another supply that they have to buy.
yeah, small expense relative.
Relatively, yeah. The only caveat to that is if you are a BLS transporting agency, yes, you can use the free version, but if you bill, you need to buy the billing package add-on, and that's kind of hefty. So the agencies that have had to look at that, we've had conversations with them, and we are basically trying to push them towards buying a full-blown version, which is ultimately less expensive.
Question, Jeff.
Yes.
How is a BLS first response PCR tied to a transporting crew? So in other words, how do we know that we're not dealing with two separate patients, but it's the same patient in the continuity of care?
Pretty much, I would have to look at those individually by date and time. There is nothing in the system that would necessarily tie those together. If you have, in fact, I don't even know if it would work with the free version, but if you have two agencies that both use, say, Zoll, one agency is on scene first, they can sync their tablet to that responding unit's tablet and push all that information that they have to theirs, which ultimately would sync it within our system. But that doesn't work cross-platform.
Does it have the potential to double count calls? Like
No. No, not at all.
Why, Jeff? Just how not? So that's my same concern. And even like, let's say you have an overdose where first response gives Narcan, and then the BLS or ALS unit then gives Narcan. How do we know that that's not two patients?
From looking at all the patient demographics. When I write a report on that, I will see the results and I will see the same address and the same name. So no, we're not going to count those. It'll count as one call.
Okay, so you manually do that data. So you're doing it for the system.
It doesn't do it automatically yet.
It really can't. And it's downloaded as a CSV file. So all I do when I put that into Excel or later when I put it into Google Studio is simply look for and delete the duplicates.
I just wanted to add one thing on the PCRs. We will still have paper PCRs, but we will not be getting them here. So the state has created a portal where if anybody chooses to stay with paper PCRs, when they get done with their PCR, they're going to have to upload them to that portal and scan the PCR in from their agency. So we won't be seeing paper PCRs here, and we won't be distributing them anymore. So our part of PCR, paper PCR is gone, but they still might see it at the hospital. You still might get some some of the pink sheets that they drop off there from people coming in that are not using electronic. So if they choose not to use the electronic system and they want to stay on PCR, on paper PCRs, they can. But when they get back to their station, they're gonna have to key in 40 data elements and scan in a copy of the paper PCR.
Yeah, this is Dr. Larson. I actually was on the call. I had trouble unmuting myself. So that was my question, because, you know, right now, a lot of the volunteer agencies do the paper PCR, and then the ALS fly car, you know, submits an electronic PCR, and a lot of times those just don't get matched up, at least in our medical records, and even at the county level or at the area level.
I think we'll have a better opportunity to match them up when we do have an electronic, at least the demographics of the patients that were electronic when they are keyed in by the agencies that are using the paper PCRs.
You would think that that's something that could easily be done electronically after, like, once the data's there, you know, you just have one program that screens out same time, same address, same name, you know, and merges them or something. I don't know.
That would be done at a hospital hub level.
Jeff, how's the chest pain thing going? Have you run it again since the EKG?
Time to 12 lead. It is actually looking much better than it was. We're not always at the 10-minute mark or prior, but a lot closer.
That's good.
Yes. ePCR submissions too, overall, we've seen about a 40% reduction in late PCRs. So most of them are being submitted in the 4-hour or less time range. And even the ones that are in excess of 4 hours are predominantly under 12 hours. So we're looking at the same shift, which is substantially better than what we have been seeing.
Did we talk about, I don't know if we talked about this at the last REMAC meeting, because we talked about it at the REMSCO and kicked it off as an initiative. The 12 lead, door to 12 lead times.
Right.
I don't know, maybe no one on the call knows about it.
That's possible.
It's on the agenda for new business, Mark.
Right.
Oh, forgive me.
Anything else, Jeff?
I think that about does it.
Okay. Protocol committee, Mike?
Thank you. So yeah, we did discuss the QA advisories and documents, and again, that's on the agenda later. So we'll just wait and let that presentation happen. The SEMSCO CMAC did approve several protocol changes, which we're all awaiting to come out. So some of that includes substituting different concentrations of liquid acetaminophen, TXA to trauma and postpartum hemorrhage protocols, with RTAC and medical director and training approval. Also up to 1 unit of type O negative blood. Another is the self-administered isopropyl alcohol for nausea patients. Nasal capnography for sedated, excited delirium patients when feasible. There's a new epistaxis protocol with the use of a topical decongestant spray. They revised the airway protocols to match the 2020 AHA guidelines, targeting SpO2 to greater than 92%. Current is 94. And also every supraglottic airway and endotracheal tube place must have a viral filter attached. The other things that we have open here on a local level is Dr. Papish was still going to be working on the leave at home protocol. Did you want to comment at all about that now?
What were we doing? I mean, we were just as I recall, we were just going to send out a reminder that the medical control is sort of required in our area, right? Unless I'm missing something.
Bill, is that where it was? You were just waiting to get that from him?
Which may be why, since I forgot,
Yes.
why you've been waiting.
Okay, and so we obviously we can deal with that offline. The other thing that's still in the works, and also, you know, Dr. Papish did some follow-up, and it just needs to be worked on now. Sam Benson and I are going to take that as the stroke flow sheet. And so after communications, it is going to be for EMS bypass to endovascular centers using the New York City SLAMs, should include LVO syndromes up to 24 hours. Also including functional wheelchair bound people. Dr. Papish, any more on that?
Yeah, that was it. We got 2 out of the 3 sites that do the procedures gave their feedback. They wanted 24 hours. I don't know, you know, the interesting thing about doing 24 hours is if somebody's at 22 hours and you bring them, they're not eligible by the time they get their imaging. So, I mean, it may be just easier to make it 24 hours just because it's close enough. And then we could just say excluding bedridden patients. There was some discussion about the, you know, like how we could as a group or as the EMS providers as a group be able to elucidate who is a well-functioning wheelchair bound patient versus a non-well functioning. But I think that's just too difficult to do pre-hospitally, like to differentiate and set up some sort of a, you know, it would make the protocol much more confusing. And so I think it's probably best just left as bedbound patients excluded, wheelchair patients included. We have to vote on all that, right?
It looks like Pam is shaking her head
Well,
yes. I don't know if you want to.
Once it's finally all solidified and we have it written out, yes.
And that is all I have. Thank you.
Okay, thanks. Under new business, we sent out a few advisories since the last meeting. Mark, do you want to comment?
I'm so ill prepared.
No, it's okay. So the first one was the documentation completion. We did the one about people getting their documents into the, you know, completed and into the system before they leave the scene within 4 hours, preferably, because Jeff had, you know, reported out to us he was getting EPCRs like so late, days out, which was just not a good thing. So we did cause a little turmoil to some agencies because Mark and I signed this advisory to go out, and some of the providers in the field, because we sent it directly to them, they got really freaked out about it and were like, I can't take another call till I do this documentation. So we're trying to work the middle road here, but it's working well. Jeff, I think you can corroborate that, right?
Yes, I can.
And your numbers now for completion under 4 hours are up to what?
We're at about 75%.
And we started at what?
About 25 to 30%.
Yeah, it was like, I was going to say below 30%.
And that was just one
Yeah.
edict and statement. So, I mean, it sounds like it was really easy to do for the vast majority of calls.
Yeah,
Yes.
and I think that it's just, sometimes some people have an aberration to having to complete paperwork, and to complete documentation. You have your guys in the departments. Some people get their notes done before their shift is over, and some people, it's days later are doing their notes. So I just think, it's the best thing is to get in the habit early on, do your notes. I tell the residents, do them right then and there, just because it's fresh in your mind, and get it done. And that's the way we should, move forward throughout our career. So that was what we were kind of trying to instill. And then the other thing was the 12 lead acquisition.
Yeah, I mean, that was just recognized as a problem when we looked at now that we have this ability to do these large data screens, that the time of arrival on scene to the time an EKG was done was tremendously long, far below what we consider to be a standard. And once again, that too looks like it's just improved with an email and a letter. So it's great. So we'll keep tracking it.
Okay, also, under new business, I have a couple of announcements. Dr. Raybridge has turned over the directorship of NIAC to Dr. Greenhut and has been promoted. Congratulations, Jeff, to a more regionalized director position at Envision, and will oversee quite a few of our local hospitals in our area. And a notice that Montefiore NIAC has been approved by New York State Department of Health for an interventional cardiac cath lab as of February 1st, 2021. So they are now added to the list of STEMI receiving facilities in our region. Anybody else, anything under new business? Or I'll move on to.
Yeah, this is Eric Larson. So I have a question. It's about restocking. So when ambulance crews pull in and they take care of a patient, they're bringing a patient to a hospital, and let's just say, for the example, they've been at SVT, they've given a couple rounds of adenosine, they turn the patient over, transfer it to the emergency department crew. Where and are they restocking those vials, with those vials or whatever the medication is of that they use in the treatment of that patient? Are people getting restocked from the hospitals? Are they restocking from their own supply? I mean, this has now become a fairly big issue down here in Westchester. We're discussing it. Basically, what at least Westchester REMAC had put in place back in 2007 was that any formulary medication, we're not talking about controlled substances here, we're just talking about stuff on the formulary. When you use something that was on the formulary in the care of that patient, you could get restocked from the hospital you brought that patient into. So I'd like to hear what people's experience, what's going on, Hudson Valley, do we have a policy, any of those kinds of things.
So I'll open it up to the group. There is no official policy. I think it's each hospital does a different process, actually.
Yeah.
Ashad, can you talk about Vassar?
Yes. So we resupply and we modeled ours actually after the Remo region. And we resupply medications, disposables like IVs, IV start kits, linens and clean sheets in a one-to-one program. So yes, we do it.
So any of the other directors, Dr. Cohen, Dr. May, Dr. Mao, do you want to talk about your facilities?
Hi, it's Dennis. I don't believe we're
Yeah.
Hey, Pam, I apologize. I'm on simultaneous call. What was the question?
They were asking how we restock when a crew comes in and say they had a patient with SVT and they had to use medications and they need to restock. Do we fully restock them, or is it only specific things that they're given from our storage?
I believe it's only specifics, and not meds, to my knowledge. The actual hard equipment like IV supplies, all that stuff, that 100% they could take. They have access to most of that stuff, but as far as meds, not that I'm familiar with.
Yeah, I'm the same thing at St. Luke's, just IV supplies and boo bags, but not medications.
So that's the gist of it. Dr. Larson, I think that most people, it's, the stock equipment, IV fluids, IV bags, things like that. So not true medication. So I think that the relationship of certain hospitals with cores have happened in the past with certain meds, but it sounds like it's all kind of gone to the wayside now and just stockpile of supplies.
Dr. Murphy?
Yes.
I can add to Dr. Arshad. Ours was vetted through compliance quite rigorously to meet any compliance laws that are there. But we do restock the full formulary.
Yeah, OIG got involved in this a while back and said, is it a kickback statute? They're going to bring you patients because you give them the medications back and these kind of things. That's where this was all stemming from. And it used to be, much more free flowing, and then it kind of came to a screeching halt. But there still are some institutions that do supply the medications that I know of. I just was wondering everybody out there if, what their institutions do for Dr. Larson. Any other comments?
So, when we did the 2007 policy of the REMAC down in Westchester, we incorporated all those issues in terms of, is this kickback and so on and so forth, and the questions of double dipping, because of your itemized billing. And then there's, always the question of how the emergency department bills. Can they bill for that patient? Can they bill for that drug that was given pre-hospitally? So there's just a lot of questions, and what we found is that even though there was a policy in Westchester that some of the hospitals have drifted away from it, some of the pharmacies are balking because they say, hey, why should we be resupplying even though it's on a one-for-one on these patients who are being brought in here? We don't think we should be doing it. But there's also the sort of, patient safety. Let's say you're going in, you burned your entire stock of adenosine, and it just so happens to get banged out immediately on another 911 call and happens to be an SVT patient. And where are you going to restock? Or all of a sudden you arrive on the scene and you don't have those. So it was sort of viewed as a patient safety and getting 911 back in the system, the response angles back in the system faster.
Yeah, I mean, what you bring up is a very valid point that absolutely can happen, I would think, quite readily, especially like even after a cardiac arrest. If you imagine all the medications they can go through if they, stayed on scene and did a good resuscitation like we like them to do, you could blow through your supplies in the medication. So maybe this is something we need to look at and revisit. Maybe we can have protocol committee look and revisit that, Mike. I don't know if that's something, are you ready to shoot me now that I say this? But something we can talk about for our region, just as, Westchester took a look at it, that we look at it again.
Certainly, I'll add it to the agenda.
Thank you, Dr. Larson. Good point. So next is CMAC. We talked quite a bit about that already. I talked about the iGel presentation we did. We did a lot of discussion about COVID-19 vaccine and just, the whole process behind it. There was a lot of revisions to certain procedures brought forward from New York City, mainly, looking at some of their protocols and some new additions and rewording and such. And there was, discussion about some of the projects going forward. But I don't know, Mike, can you think of anything else? Am I missing anything from CMAC?
No, when I looked over my stuff, that was pretty much everything that we had done.
Yeah, I think that was the gist of it. we are solidifying the dates for the new meeting. So that'll be next time we get together. Anything on open forum?
Hi, it's Dennis. Just one thing. I just wonder if the group thinks that we need to do something to help out the crews about the crews taking pictures on scene. I'm running into a lot of crews that are taking photos on scene. They rotate in multiple places and are being told that the trauma surgeons want photos from scenes, accidents. That sounds like a HIPAA violation that goes on. So I wondered, does our group need to send out an advisory telling the crews don't take photos?
You just have to be able to do it in a HIPAA compliant way with an encrypted program. And then it's not an issue. I think to your point, the reality of how many pictures people are taking, probably they're not using that.
But once they take it, that means that they're at risk because there's a new law that came out that allows the lawyers to subpoena your phone and take your phone for the pictures. And if they show someone else, that's a HIPAA violation.
Right. I mean, if you're using encrypted software, like for instance, Tiger Connect or what's the some of the platforms delete automatically after 3 days.
Right. So maybe we need to send something to remind people that they're taking it needs to be a HIPAA compliant system. Otherwise, people are going to take it with their regular phones. We're not even talking about them posting on their own agency's websites, just for them taking it.
Yeah, that's a different disaster.
Yeah, I think you bring up a good point, Dennis. We actually it took us about a year, I think. We wanted to be able to take pictures of various things, whether it be wounds or things you repaired or things that presented to the emergency department, pictures of assaults, pictures. We wanted pictures to be put into our medical record. Throughout our whole, lives, we've been taking it on our private phones, and we got in, pretty much hot water with our legal aspect of the hospital here. But now what we've been able to do is we upgraded one of the platforms in Epic so that we can upload these pictures now in a HIPAA compliant forum. But again, they have to be done with a specific format and in the hospital. They would not be pre-hospital pictures of any nature. But it's a thing where it's really a hot button item right now.
Right. So maybe something we just send out to remind people, and this allows the crews to be able to, when they run into the trauma surgeons, they're being ordered to take pictures, and they need to use a HIPAA compliant system. That would be fine. This would then help the crews stay out of trouble with the receiving providers.
Yeah, James just mentioned in the text, triage is HIPAA compliant. So if you take it via the triage app, it deletes or, it doesn't stay on the person's phone.
That's fantastic. It'd be great. But I guess maybe do we want to send something out to the region, tell everyone, hey, use a HIPAA compliant system? I mean, people are going to take pictures, understood, but at least do it correctly.
Yeah.
There you go, Mark, another advisory.
We just keep throwing them out there.
No, but we could. I mean, I think the recommendation of using the triage platform is really, important. And I think, most people out there are using it now so that they could put the photos in that HIPAA compliant manner and not be in, jeopardy of getting, subpoenaed for their phone or something of that nature.
We've got a pretty low triage utilization in our building, so very few crews are using it with us.
Really? I thought they were using them a lot down there.
Not with our building. I mean, maybe other buildings, but it really doesn't help us very much. We're not seeing the benefit from it. It's actually more problematic, especially with the sicker patients. We're not getting the information we need. But yes, it's fine for the whole system, but that's a totally separate issue.
So what we'll do is we'll work on that, Dennis, and maybe circle back with you and send you something, and then we could, put it out as a joint, memo from or advisory from the committee.
Fantastic. Appreciate it.
How many advisories do we send out a year, you think?
that many.
Is it? Okay, because I was like, should we, my only concern about like sending a lot of advisories, which I think, obviously, I'm not saying that this shouldn't go out. This makes sense, but we have a lot that makes sense. Creating like advisory burn, burnout, where people like when I get inundated with emails then about someone, then I miss their emails somehow. So I guess we don't send out that many, but is it something we should do, like a quarterly advisory? Like, I mean, do we send more than 4 or 5 a year?
No.
Okay.
I would say probably no more than 6 a year ever.
Yeah, very few, because you and I have to sign them, so.
I know, but I'm trying to think. I feel like we have a lot lately,
Yeah.
more lately than in the past. Mahoney wanted us to send one about glucometry. He brought that up as an issue. I don't know if he's on the call.
What was the issue?
Well, there were patients that have their own blood glucose detection devices that don't require finger sticks anymore, as the technology sort of advanced. And I guess there were a couple cases in Dutchess where, providers insisted on poking people when they had their own way of reading it, which worked quite well without actually involving a finger stick. And just to say that is permissible. I don't know whether it really needs an advisory, just because 9 times out of 10 people would be like, this is my reading,
Yeah, I would think that would be straightforward. Yeah.
What?
I would think that would just be straightforward. Okay, anything else under open forum?
One thing, Dr. Murphy, as people are taking your advice and reading our medical services guidelines, we are going to be getting updates as to those hospital capabilities. And so what we plan to do is update the document, send it back to the region to post online. So you will have a most up-to-date online document, but not necessarily keep sending it out each time someone else says, hey, this needs to be changed. So we'd like to just leave it online so that you can download it at whatever moment and it'll be the most up-to-date.
Perfect. Anything else from anyone?
2 items. One, Anthony just chatted me and made me a reminder. Is there any update on the status of BLS capnography? I think we were asking, doing an inquiry, Bill, as to whether there's any standard or anything at the state level regarding it. Remember there was it Beacon?
Right. We haven't heard anything with it. The only thing is, if the iGel project does go through, it will require waveform capnography at the BLS level, and then we'll have to set up that standard. So I was thinking that we would probably just move along that line when that, if and when that comes to fruition.
So for in the interim, for agencies that have that capability, because their EKG machine also does that, I mean, there's no real reason they can't use it if they're appropriately trained, correct? Or in service.
I am not aware of any reason why they wouldn't be able to use it. And Jeff, do you have an opinion on that one?
It should be a standard of care at any level. Really, anytime we're giving oxygen, anytime we encounter a patient with some respiratory distress, we should be doing CPAP, or excuse me, and tidal.
Yeah, I mean, it's not a standard of care right now, just because it's not something that most BLS units have the capability to do, but some do. And so if they have it and their medical directors train them and using it, I mean,
I think that should be sufficient also, as long as they get the proper training and how to use it and how to interpret it.
Question is, like, if you're using it as a device, is there any risk of misusing it and causing harm? I mean, if you make an actual provider error, like in that resuscitation case that we talked about earlier, but I think that's, unlikely. You wouldn't think, and that was sort of outlier scenario that transpired, I would hope.
Well, I think it would come down to the amount of times that the BLS provider uses it and maybe require additional training. The agency would have to require additional training if they don't use it, frequently.
I guess the question is, is there anything that we need to do, or should we need to make any kind of policy about that as a region? Or is this something we should just let slide until the IGL project comes to more in front and center?
Mark, are you saying that you'd like to sign another advisory?
Well, if I did it quarterly, we could just kick a few out in one letter. No,
Actually,
I
I looked quickly here in the national guidelines, and it is in here, and it appears to be in here for BLS providers as well, which means it's within the scope of practice.
Okay. So we don't really need to do anything then.
I think the biggest hurdle there is education and people being comfortable with the equipment and really having some kind of background knowledge about waveform capnography and end tidal CO2 and just all these things. I think that that case that Dr. Ashad brought up totally shows that you can have a good paramedic, which he realizes this is a provider that's quite capable, but yet totally misread that reading. So I think it's an educational thing. And as directors of all these corps, we need to make sure that our guys are up to snuff and maybe every so often do a refresher, some kind of a way that we make sure everybody is still comfortable with the equipment and the knowledge base. Any other additions for open forum?
The last thing I was gonna, sorry, for the stroke diversions, do we want to, the only two things that we had left were that the bedbound patient versus wheelchair and the 24 hours. So do we want to vote on it, or do you want me to make a final document that we could send out to everybody before the next meeting? Or
You could do a final document and then send a poll, a web poll, and people could vote off on it, because we presented it last meeting. However, we needed to, make some tweaks there that you talked about. So, not to have it wait until the next meeting, or if you wanted to, either way. It'd be nice to get it out.
yeah, we'll finalize the document and then we'll poll everybody, and that'll count as the vote, correct?
Yeah, we can do it as an official platform.
Sounds good.
Okay, anything else for anybody?
Motion to adjourn.
Yeah, thank you. And a second? All right, thank you, Dr. Ashad. All right, thank you, everybody. I know everybody's schedule is so busy, but I appreciate it. At least we can get some good stuff done here remotely and on Zoom. Thank you so much. Have a great day.
Bye-bye.
Thank you. Bye.